Thanks, everybody. Thank you, Asahi, for the invitation. I'm going to talk about basically what I think I've done well in my career, which is practice building, both in academia and now that I've seen the light outside of academia as well. So, I think in general, nothing is easy, right? But with MSK embolization, there is a very big opportunity. I think it's basically because there is a true treatment gap. I think if you look at things like prostate embolization, sure, it works excellent. But the reality is that there's a lot of surgical options, and we're essentially competing directly with urologists. Whereas with MSK embolization, there's estimated 5 million patients alone in the US who basically have medically refractory disease that's not amenable to surgery, whether they can't have it or don't want to have it. So these patients literally have no other options, and they're just sitting there with pain. So there is a basically pool of patients that sort of need procedures like this. And so much that oftentimes these patients are desperate. They're paying out of their pocket for things like stem cells, PRP, other experimental things. So, I think in general, practice building is, very straightforward in that it comes down to the basics, and the classic 3 A's are always very important, being available, being affable, and being able, right? So we talk about being available. That means, always sort of having a quick response time, whether that's, giving out your cell phone or your email, but then it's also not just you, it's also your staff, right? Oftentimes your staff is actually the gatekeepers, and so you making sure that they're also available. I literally actually texted my staff while listening to you about a patient that I just got referred. So just being able to sort of get patients quickly through the door is important. And then of course, being friendly, looking to help, offering these sort of providers a solution is very important. And then being able, you obviously have to be able to do a good job. And I think, Yuji showed very nicely, what we can do with the skill set that we have and how we can sort of treat these patients safely, effectively, and efficiently as well. So, just very briefly about my journey, I was inspired by Yuji's work back in 2019, 2020. This was about 5 years after his initial publications, and this was a very nascent field at the time. And really, I think Sid and Sunny were kind of the only two people that I knew personally that were doing it. So I really relied on them as resources to start my practice. But I think things have changed a lot. But initially when I started, there was a very, very strong opposition to GAE, especially because at the time, and they weren't wrong. It was experimental in the U.S., and so I think instead of being upset, I really used that as an opportunity to actually try to grow this and sort of, it's been amazing to see what's happened in the last 5-6 years, but really try to, do this responsibly. And so I obtained an IDE from the government and started a sort of very small pilot study. And as you can see, though, there is a treatment gap. There is a need. And this was just my U of C experience before I left. You could see the volume, was basically on an exponential curve, so much so that our compound annual growth rate was about 40%. And we hit some fun milestones along the way. This was our 100th patient that we treated and a 104-year-old patient that we treated. And so it was really rewarding to kind of build this practice. And just as a corollary, that took about 3-4 years to get to 100 patients in the university. I think within 6 months of being in prior practice and sort of focusing or dedicating my career to this, we were able to reach 100 patients. So there, like I said, is a real opportunity. So how did we get here? This is really probably what the sort of meat of my talk is these are some of the pearls that I've learned along the way. I think the first that should be obvious, but sometimes doesn't appear as obvious, is that there's no gatekeeper of OA. Unlike prostate, unlike fibroids, unlike hemorrhoids, this is a disease managed by everybody and anyone because of so many patients there. So it's really sort of incumbent on you to sort of knock on everybody's door. You can see this sort of map that I've sort of shown that how many different people sort of manage these patients. And that actually includes IR too. So before GAE, we were managing these patients too, right? Whether it's steroid injections and things of that sort. And so because of that, there's opportunities to sort of get referrals from many different sources. The second pearl that I would say is don't be a one-trick pony. I think if you really want to invest in this space, as I just mentioned, as radiologists, we've always managed knee OA for a long time, whether that's diagnostically, but also, we've always done injections. We've always done sort of pain management things like nerve ablations, and very recently, myself, we've started doing peripheral nerve stimulators as well. So you can be very, very comprehensive with how you manage these patients. And, I think as I've grown in my career, I've realized, you don't want to just sort of see a patient, do a procedure and say, oh, it didn't work, and then send that patient back. That's not as helpful as seeing a patient, trying something, if it doesn't work, and then offering 2 or 3 different things. And we have this skill set to sort of do all of those. So because of that, it's really, I think, very, very helpful to build a comprehensive program, because then, if you try multiple things, your outcomes inherently go up. And so that's ultimately what we want. We want patients to be satisfied, and then the referring docs are also satisfied because you found a solution for them. It doesn't have to be necessarily GAE. And then the third pearl, sort of in that line, is you want to take a different approach with different specialties. I think surgeons and basically non-surgeons look at diseases very, very differently, right? And so non-op docs are focused or trying to get their patients solutions without thinking of surgery. So this is an opportunity to sort of do that for those docs, whereas surgeons, it's like, they want to cut everybody, right? This is just the kind of the stereotype. But the reality is there's a percentage of patients that they can't cut. So those are the patients that they are often, looking to sort of refer to you, or the patients that they've operated on that they don't, can't operate on more. So that's sort of, philosophically a different approach to somebody who's looking for a non-operative approach. And so that leads me to the next thing, which is I think GAE has significantly advanced, in half a decade. But the reality is still most non-IRs, most referring doctors don't know what GAE is, right? And so it's practice building in this situation is not about competing with your neighbor. It's about actually just educating, these referring docs. And so I think, again, back in the day, it was trying to do this through research, but now it's a lot more sort of understanding this is no longer experimental. We just published, the SIR position statement, sort of identifying that the data is pretty mature now. We have CE mark approval in Europe. We have multiple IDE studies. So really sort of using or harnessing that data to sort of go out and educate and sort of say, hey, look, this is not just some crazy procedure being done in Japan. This is something that's being done in the world, and we have a lot of good data to support it. Obviously, national media coverage helps, so things like this, Washington Post article really help legitimize this as well. And so just using this as an opportunity to educate both patients as well as referring docs. With that said, you still opportunities to grow through research. It is, while it is, I don't think it's necessarily experimental, there's still a lot more we can do, right? We have a lot more studies that are being underway. And I think anyone who's looking to get into this, whether that's through a registry or a clinical trial, those opportunities exist, and I would highly encourage you to do this before insurance denials and things like that will force us as a specialty to do that. And this is just our RCT sham study that we just transferred to the University of Utah any day now. And then, just some publications we've had along the way, just the opportunity to sort of, this is another opportunity to educate is just through, doing these types of studies. And then, I think the other important thing is, find stakeholders that are really interested in this. I think in a lot of things, you just need 1 or 2 really good docs that believe in this, that manage this disease, and they become kind of your, best referring docs. So this is just an example that at the university that, we built a very comprehensive program with multiple specialties. So we weren't in a silo trying to compete with people. We were trying to integrate this procedure into the paradigm of knee OA treatment. So just to conclude, I think GAE and MSK embolization as a broad topic or sort of field is an exciting new arena in IR. It takes a lot of work, but there is a real treatment gap. So the bar, I think, to build the program is a little bit lower than other things. And I think this involves in sort of engaging multiple different specialties, finding patient solutions, and as well as research. So thank you guys.